So what is treatment of anovulation? And in this, we will be discussing what is PCOS also. So let's first start. What do we do for a patient who has infertility and anovulation, or basically infertility and PCOS? What we do is ovulation induction. That means we have to induce ovulation in these women. Okay. Now there are two other terms which you may come across. One is super ovulation or ovulation enhancement, and the other is something called as controlled ovarian hyperstimulation, or COH. So you should also know what these terms mean in case a question comes where these terms have been used. So if we are inducing ovulation in a woman who is anovulatory, it is called as ovulation induction. If we are trying to enhance the chances of her getting pregnant despite her already being ovulatory. For example, a woman is having unexplained infertility. She is having ovulatory cycles, but still we give her ovulation induction. We give her clomiphene citrate. This will cause multifollicular development, or multiple follicles will form, so her chance of pregnancy will increase. She's not anovulatory, she's ovulatory, but we're just giving her drugs so that she has more ovulation, more follicles develop. This is called as super ovulation or ovulation enhancement. So if you're doing ovulation induction in a woman who is already ovulatory, you are giving ovulation induction. It is called as super ovulation. And if you are doing ovarian hyperstimulation, so this word COH is referred to IVF cycles, जिसमें हम क्या करते हैं IVF cycle में क्या करते हैं, basically in IVF what we are doing is we are causing controlled ovarian hyperstimulation. That means we are inducing the ovaries to produce a large number of follicles, बहुत सारे follicles. And then what do? We aspirate those follicles, what is called as oocyte aspiration, by a ultrasound guided needle. We aspirate the follicles, collect all the oocytes, give them to the embryologist. He or she will do the IVF, the fertilization in the lab. And then the embryos, we transfer them back in the uterus. So the stimulated ovaries in IVF, that is called as controlled ovarian hyperstimulation. So there are three different terminologies which basically mean the same thing, but they are used in different situations. Now, what are the drugs we use in ovulation induction? One of the first drugs we ever used was clomiphene citrate. Okay, clomiphene citrate is a drug which is basically an anti-estrogen. So the mechanism of action is anti-estrogenic. मतलब वो estrogen levels कम करेगा. Estrogen levels कम होंगे तो क्या होगा? FSH levels बढ़ेंगे. FSH levels बढ़ेंगे, that means multiple follicles will start getting recruited. So multifollicular, it causes multifollicular development. ठीक है? And because it causes multifollicular, 2, 3, 4 follicles may start developing and growing. There is a higher incidence of what? There's a higher incidence of, anybody? Am I stuck? No, good. So yes, very good. So a higher incidence of multiple pregnancy, twinning, triplets, quadruplets, I have seen them all. So multiple pregnancy ho jata hai. ठीक है? So this is how this acts. Now the second thing you should know about clomiphene is कि हम कैसे देते हैं. So we usually give we give it on day 2 to day 6 of the period. That means we start on day 2 and give it for 5 days. The starting dose is 50 milligram per day. So for 5 days, the maximum you can go up till is 150 milligram per day. Suppose she doesn't respond to 50, next cycle you give 100, then she doesn't respond, then you can go up till 150 milligram per day. ठीक है, so we give it for 5 days. फिर हम क्या करते हैं, हम पेशेंट को डे 10 पे बुलाते हैं. डे 10 को हम क्या करेंगे, वी डू एन अल्ट्रासाउंड, एंड दिस अल्ट्रासाउंड इज कॉल्ड एज फॉलिक्यूलर imaging. That means we look at the developing follicles. Ki one follicle develop हुआ, 2 हुआ, 3 हुआ, and we follow the follicle. That means we do an ultrasound almost every day thereafter till the follicle reaches 18 to 20 millimeter. When the follicle reaches milligram में बच्चे, when the follicle reaches 18 to 20 millimeter, we give a trigger. What is the trigger? The trigger is something which mimics the LH surge. Okay, what drug do we give which will mimic the LH surge? But it is milligram, है ना? You can see यहाँ पे भी लिखा हुआ है ना? Please don't distract me, please. What do you mean by trigger? Trigger means something which mimics the action of LH. And what do we do? So LH as such market में available नहीं होता है. FSH available है, but LH नहीं है. LH क्यों available नहीं है? Because LH is a very volatile molecule. It has been found to be very volatile. You can't store it. So trigger we give in place of LH, we give HCG. HCG has been found to very well mimic the action of LH because of the structural similarity. HCG has alpha unit, beta unit. LH has alpha, beta, and the alpha units are the same. So it's very structurally similar to LH. So HCG is given. What does HCG do? It causes the final maturation of the follicle of the oocyte and it induces ovulation. So it causes rupture of the follicle. So HCG को देने के बाद 24 to 36 hours बाद क्या होगा? Ovulation होगा. So after giving HCG, the ovulation will happen. So we can advise the patient to have timed intercourse. That means we give the HCG and we tell them that the follicle is likely to be ruptured after 24 hours. So they need to start having sex. Okay, so this is called a timed intercourse. Or we can time the if we're doing intrauterine insemination. Suppose there is a problem with coitus. Suppose the husband has erectile dysfunction, or the husband has premature ejaculation, or the girl has vaginismus. So some coital problem is there, then we usually prefer to do an intrauterine insemination. So we can time the IUI or the sex according to when we give the HCG. Okay, this is what is done in clomiphene citrate. Also remember that we are worried. Clomiphene citrate is a good drug. 80% of patients will ovulate by giving this drug. So it has a very good success rate. But there are certain problems with clomiphene. What are the problems with clomiphene? With clomiphene, there's a higher risk of, one is multiple pregnancy, twinning, triplets, quadruplets. Okay. There's also a higher instance of ovarian hyperstimulation syndrome, which is more common with IVF. In IVF cycles, when you're doing controlled ovarian hyperstimulation, but it can be seen with clomiphene citrate also. What else with clomiphene? What are you worried about? Over time, it's an anti-estrogen. So it has anti-estrogenic effects on the endometrium. It causes endometrial thinning. If you use it over 6 months, it leads to endometrial lining becomes thinner and thinner, and this itself becomes unfavorable for implantation. So we usually don't use it beyond 6 months. 6 months, not used beyond 6 months. It is not used. Okay. What else? Yes, a rare visual side effect has been reported called as palinopsia. जो ऑफ्थेल पढ़ रहे हैं वो बता सकते हैं व्हाट इज पैरेनोप्सिया. मुझे बस इतना पता है पैरेनोप्सिया होता है. ठीक है. Why it causes thinning? Because it is an anti-estrogen. Estrogen causes endometrial thickening. Anti-estrogen is going to cause endometrial thinning. Over a prolonged months of usage, it will cause thinning. And very important, there is also a theoretical risk of what? Of which cancer? There's a theoretical risk of which cancer, and that's why it is again not used beyond 6 months. Yes, of ovarian cancer. Why? Because one of the etiologies of ovarian cancer is that जब follicle rupture होता है ना, surface of the ovary पे trauma हो जाता है. So the more the number of ovulations happening, the more the micro trauma on the surface of the ovary. So if ovulatory cycles are more, this micro trauma builds up over many years and can lead to ovarian cancer. That is why when we talk about risk factors for ovarian cancer, which we will be discussing tomorrow. But let's touch upon it here. One is clomiphene citrate because it induces more number of ovulation induction cycles. What else? Women who have early age at menarche, late menopause. That means they are having more number of ovulatory cycles. Women who are nulliparous or low parity, they don't have the protection offered by pregnancy. Pregnancy will cause 9 months of anovulation plus the breastfeeding wala time. So almost 1 year ke liye they will be anovulatory. So pregnancy is protective for ovarian cancer. Nulliparous or low parity has a higher risk for ovarian cancer. What else? So these are reasons because of more ovulatory cycles at a higher risk for ovarian cancer. Remaining risk factors we will discuss tomorrow because it will be unrelated to this topic. But just on this same topic, what are the based on this factor? Protective factors kya hai? Protective for ovarian cancer is high parity because less ovulation then, hai na? High parity. Women who are breastfeeding because they are again anovulatory and very importantly good OC pills. That is what I was looking for. So OC pills primary action is inhibition of ovulation. So OC pills protect against 3 cancers. C, E, O. What is C? C stands for colorectal. E stands for endometrial because the progesterone component protects against endometrial cancer and ovarian cancer. So remember CEO, colorectal, endometrial, ovarian, OC pills. This is combined. OC pills will protect against these 3 cancers, and OC pills increase the risk of which cancers? Breast cancer and cervical cancer. Okay, cervical cancer is a little query because some studies are now saying nahi hota hai. ठीक है, but breast cancer definitely it increases the risk. Okay, so this is important. We will be discussing this again tomorrow because tomorrow is mainly contraception and oncology and the few extra topics. Okay, but this is important. Now, coming back to other drugs for ovulation induction, the drug of choice, in fact, drug of choice for ovulation induction in PCOS women is not clomiphene, it is letrozole. It used to be clomiphene when I was a postgraduate, and for many years later it was clomiphene, but letrozole is now the drug of choice. ठीक है, letrozole acts by a similar mechanism. It is an aromatase inhibitor. Aromatase was the enzyme which produces estrogen. ठीक है, but this is a drug which inhibits the enzyme, है ना? So estrogen levels go down, same thing is going to happen. FSH is going to increase, so follicle will get recruited. But letrozole is not as strong as clomiphene. Clomiphene, remember, is a very strong anti-estrogen. तो FSH levels बहुत high हो जाते हैं, multi follicular development होता है. But letrozole is not as strong, so it's going to cause monofollicular development. That means only one follicle will develop, hence the risk of multiple pregnancy is not there. So there is no risk of multiple pregnancy. Twins, triplets nahi hota hai, ek hi baby hoga. And that's why it's the drug of choice, because multiple pregnancy is a high risk pregnancy. You don't want as a doctor to be giving more risk to the patient. Patient may be very happy ki twins ho gaye, but it's not a happy thing because it's a very high risk pregnancy. So letrozole is that. Hence, letrozole is the drug of choice because there is no risk of multiple pregnancy. Also, how do we give this? So very similar. Day 2 to day 6, we give 2.5 milligram per day. You can go up till a maximum of 7.5 milligram per day. Okay? And same thing. You call the patient on day 10 for follicular imaging. Once the follicle reaches 18 to 20 millimeter, we give the trigger, which is usually HCG, and then we advise timed intercourse or IUI 24 to 36 hours later. So rest is the same. The only difference is the drug, and the mechanism of action is also very similar. Okay, the only main difference is this is monofollicular development, and it is not going to cause your reduced endometrium thinning bhi nahi karta itna, because it's not a very strong anti-estrogen. Okay, yes, day 2 of period to day 6 of period, we give the drug. So 5 days we give the drug, then we call the patient, because we have to see na the follicle is forming or not. So we call her for an ultrasound. Follicular imaging is done by transvaginal scan. We simply see the size of the follicle. Okay, so letrozole is a drug of choice. This has come as a question multiple times. Drug of choice for ovulation reduction in PCOS. Now, what are the other drugs we can give? We can also give gonadotropins. Directly, we can give FSH. Well, I told you gonadotropins क्या होते हैं? FSH और LH होते हैं. But I also told you LH available नहीं होता as a separate drug. FSH available होता है. See this drug? This is FSH. Urofolitropin is FSH. ठीक है? Or you get the drug available as HMG. What is HMG? And this has come as part of a clinical question. So many students got confused कि HMG क्या होता है? HMG is human menopausal gonadotropin. That is FSH plus LH. So how do we get this FSH LH? One way of getting it is, one is you by recombinant technology. But the olden way of getting this drug is from the women, urine of postmenopausal women. We take the urine of many postmenopausal women. That's what the pharmaceutical companies do. And they extract FSH and LH. So they either purify only FSH, or they create FSH plus LH. That's called as human menopausal gonadotropin. Okay? So if you see this in the question, don't get confused. HMG simply means FSH plus LH, and it is given in women. It is a second line drug. So first line drugs are letrozole and clomiphene in PCOS. If that fails to work, this is a second line drug for ovulation induction in PCOS. It is also the drug of choice in women who have hypogonadism. So she has a pituitary lesion, okay, or say Sheehan syndrome, and the pituitary is not functioning. So giving an anti-estrogen is not going to help. You have to directly give her FSH for ovulation induction to happen, or Kalman syndrome. Okay, so hypogonadotrophic hypogonadism, you're directly going to give her FSH and or FSH plus LH. Or it is the second line drug in women who have PCOS. Again, it's going to cause multifollicular development. Depending on the dose you give, it usually causes multifollicular development. Another second line option. So second line, suppose patient hasn't responded to letrozole, hasn't responded to clomiphene. You have a choice of either giving gonadotropins or doing this procedure. This is also a second line option for women with PCOS who have not responded to first line drugs, that is letrozole or clomiphene citrate. Okay, I look tired. I'm not tired. I thought we'll finish this topic by 11, but it's okay. We're almost done with this thing. We'll finish by 12. Danush, just listen, keep listening. If you can't write, just keep listening. Okay. So second line option for women with PCOS who have not responded to letrozole or clomiphene, we can try laparoscopic ovarian drilling. So it's a laparoscopic procedure where we drill holes in the ovaries. Okay. So there is something which is called the rule of 4. By drilling holes in these ovaries, you are reducing the bulk or the volume of the ovaries, and that itself stimulates ovulation to happen. So it has a success rate of 50%. 50% of women who have undergone this procedure will start ovulating spontaneously. What is the rule of 4? That you have in each ovary. So in each ovary, you make 4 holes or four drills, okay, to a depth of 4 millimeter, okay, and you should switch on. So this drill is made by a monopolar cautery. So you're basically passing electrical energy into the ovary, and that's how you are creating the hole. So the energy should be on for 4 seconds, okay, and at a energy of 40 watts. So this is the rule of 4. 4 holes, 4 millimeter depth, lasting for 4 seconds at an energy of 40 watts is the rule of 4. It has several disadvantages though. What are the disadvantages? One is that it may reduce if somebody does an overzealous drilling. अगर बहुत ही ज़्यादा excited होके बहुत सारे holes कर देता है, it can destroy the ovary because it is electrical energy. It's burning a lot of tissue. It can reduce the AMH, so the ovarian reserve can go down. And yes, it is invasive, and because any surgical procedure and you're using energy here, it can also lead to adhesions. Okay, and these adhesions can affect tubal motility. So these are two risks associated with this procedure: reduced ovarian reserve and adhesions which can hamper tubal motility. Okay, so this is about laparoscopic ovarian drilling. Now, since we're discussing anovulation, we'll discuss about PCOS also here only. A little bit about PCOS. So PCOS, we all know, is a very common problem in girls and women, and it is defined by what is called the Rotterdam criteria. Rotterdam criteria says 2 out of 3 होने चाहिए. क्या होने चाहिए? First is hyperandrogenism. ठीक है? Hyperandrogenism could either be clinical or biochemical. Clinical means the woman or girl will come with hirsutism or acne. These are the two common clinical things we take into consideration. And biochemical means there's a raised testosterone or dihydroepiandrostenedione, DHEAS. Okay, so raised testosterone or DHEAS levels or clinical evidence of hirsutism or acne. The second thing is menstrual irregularity. That means delayed cycles. Okay, that is oligo-ovulation or anovulation. Okay, so that is the second criteria. And the third criteria is polycystic morphology. What I just showed you, that ultrasound जिसमें ये वाला pattern है, the necklace pattern. This is called a polycystic ovary or polycystic morphology. Paracetamol नहीं है, polycystic. Thank you, Krishna. Polycystic morphology. Polycystic morphology का मतलब है this kind of ovary. Now, the exact definition of polycystic morphology is if you have more than 20 follicles in one or both ovaries. जरूरी नहीं है both the ovaries. More than 20 follicles of the size 2 to 9 millimeter is the new definition of a polycystic ovary. ठीक है? पुराना definition था more than I think 12 follicles. Now it is more than 20 follicles in each ovary. It could be in either one or both ovaries of 2 to 9 millimeters. So these are the small follicles. You basically count. Like you have this ovary here on the ultrasound. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. ऐसे अगर 20 या 20 से ज्यादा हो. ठीक है? Full form किसका बच्चे? PCM means polycystic morphology. ठीक है? Polycystic morphology is PCM. ठीक है? This is change this to 20. So more than 20 follicles in one ovary and or ovarian volume more than 10 centimeter cube. But the newest guidelines say that the best way to say polycystic morphology is not the volume. You can use the volume ka definition, but more than 20 follicles in the ovary, and the follicle size should be between 2 to 9 millimeter. You can give gonadotropins, Dr. Shubhra. I said you can give second line में या तो gonadotropins आते हैं या laparoscopic ovarian drilling आता है. Either of them is fine. Usually we do laparoscopic ovarian drilling if you are suspecting another pathology also. तो मुझे अगर tubes भी check करने हैं या मुझे लग रहा है कोई और pathology endometriosis है, I can check at the same time. That's when I will want to do a laparoscopic drilling. Yes, so I that's why I didn't mention this. So Rotterdam criteria still says 35 days, But then, as per the new FIGO definitions, abnormal cycle is now more than 38 days. तो इसलिए I didn't mention this because there's a disparity. Just remember delayed cycles or an ovulation. ठीक है? But remember for Rotterdam you have to have 2 out of 3. तो जरूरी नहीं है कि ovaries में polycystic morphology हो. Even if the ovaries are looking normal, but she has acne and she has oligo-ovulation or anovulation, she is PCOS. So remember, the ovaries are not a must criteria. Any 2 out of 3 means Rotterdam, means PCOS. ठीक है? मैंने टीटी कहाँ लिखा? टीटी नहीं लिखा बच्चे, increased testosterone लिखा है. ठीक है? Now coming to treatment of PCOS. So I want you to all pay attention here. Treatment of PCOS. Okay. And we're going to do this under different age groups because question kaise aayega in the exam, they're going to give you a clinical scenario and they're going to ask you what is the treatment. Treatment of PCOS for all patients. Remember, PCOS usually happens in a setting of a high BMI. Girls, jinka, Swagat, just remember 35 days as per the definition of Rotterdam. Okay? BMI high is usually associated with all, not all, more than 90% of girls or women with PCOS have a higher BMI. So when we talk about treatment of PCOS, you should know that the for all age groups, no matter what the complaint, the first and the primary objective is lifestyle. So she has to get into a healthy lifestyle which involves both diet and exercise, and the goal is to optimize her BMI. Doing this itself will correct most of her problems. Okay? Second is you're going to counsel her about the long-term effects of PCOS, that is metabolic syndrome. Girls with PCOS are at a higher risk of developing metabolic syndrome. Okay, that is hypertension, diabetes, obesity, hypercholesterolemia later on in life. Okay. So this is common to all age groups and all complaints. Now we will further divide PCOS and this is going to be your primary answer. अगर कोई भी question आता है on PCOS, no matter the symptom or no matter the age group, you have to advise this to all patients. So this is going to be your treatment of choice for all the women in any question that comes. ठीक है? इसके अलावा we'll now go to different age groups and different complaints. So the first age group that comes commonly to us in the OPD is the young woman. The young woman who is not concerned about getting pregnant. So she may be unmarried, she may be married, doesn't matter. पर उसको concern fertility नहीं है अभी. She may be adolescent, she may be young, she may be unmarried, she may be married, but not concerned about fertility. Okay, so not concerned about pregnancy. So usually this girl comes either with complaints of acne or hirsutism, or she comes with complaints of delayed cycles. These are the two common complaints in this age group. तो क्या advise करोगे? अगर क्वेश्चन आता है इस पे, young girl 24-year-old girl comes with complaints of delayed cycles, they've given you the Rotterdam criteria, she fits into PCOS. So your answer is you're going to look for, the first thing you're going to look for is lifestyle. So ये दोनों तो है ही, this plus whatever I tell you now. So look for lifestyle, look for counseling. These two have to be there. And then what do you do? For a girl who has delayed cycles, you can give her combined oral contraceptive pills. And those girls who have acne, hirsutism, again, you will advise combined oral contraceptive pills with the progesterone component being an anti-androgen. So most of the newer combined contraceptive pills have a progesterone component, which is a 4th generation progesterone. And the 4th generation progesterone, a good example of this is drospirenone. Drospirenone is a spironolactone derivative. Spironolactone is an anti-androgen. So this has anti-androgenic effects. Another type of OC pill which has an anti-androgen is cyproterone acetate. This also is an anti-androgen. So either give a contraceptive pill containing drospirenone or a contraceptive pill containing cyproterone acetate. Similarly, for delayed cycles, also we usually give one of these ones only because they are the better ones. Okay? So young, not concerned about pregnancy, प्लीज ट्राई टू अंडरस्टैंड कि आपने फिर एग्जाम में ये मार्क नहीं करना, आपने एग्जाम में पहले ये वाला मार्क करना है, डाइट, एक्सरसाइज, ऑप्टिमाइज बीएमआई, काउंसलिंग, एंड देन डिले एंड देन contraceptive pills. So don't look for this option immediately. Look for this option as a secondary option. So if you get a question in the INI and multiple choice, then this will be there, this will be there, this will be there. But if you just have to choose one option, please understand that the option is going to be diet and exercise. Why do we give combined contraceptive pills? Because this will regularize her cycle. It will bring the FSH, LH to baseline values. Okay, it will also, the progesterone component will correct her androgenic problems also. But this is not the solution. The solution is diet and exercise and optimizing her BMI. The solution is counseling her about the risks and educating her so she is more aware about her problem. Okay. The second category of patient is the young patient or maybe even the older patient. So I won't write the age. I'll just write the one concerned about fertility. Usko pregnancy nahi ho rahi hai because usko anovulation and she wants to get pregnant. So again, same thing. You're going to ask her to optimize her BMI first. You're going to counsel her about metabolic syndrome. OC pills will not cause ovulation. We're not giving OC pills for ovulation. OC pills act by anovulation, but they will correct her menstrual cycle. She'll get her period on time. फर्टिलिटी अगर है तो क्या करोगे, 1+2 तो करोगे, प्लस लेट्रोजोल. ठीक है, लेट्रोजोल इज द ड्रग ऑफ चॉइस. Sometimes we also, what do? We can add, so you can go first line drug is letrozole, then clomiphene, then gonadotropins, laparoscopic ovarian drilling, वो सब है. Sometimes we also add what are called as insulin sensitizers, like metformin. Okay, and this is given in those women who have evidence of insulin resistance. So not in all women. Those women who have insulin resistance, adding metformin to her ovulation induction regime sometimes improves the outcome. So this is not the first line. This again is a second line thing in women who have resistance. So your drug of choice is going to be primarily letrozole. Now the third category of patient is the even older one. Okay, like me. So I am a person who I have PCOS and I am of that age of fertility concern nahi hai. I'm not concerned about period. I'm very happy period ना आए तो अच्छा है ना. Why take that tension? So now I'm talking about the older woman. ठीक है. The older woman, again, what is your concern? Your concern is same thing. You will tell her lifestyle. ठीक है. You will counsel her about the metabolic syndrome. ठीक है. And what will you do? You will also tell her कि she needs to get her period. She needs to get her period. कितनी बार? Why should she get her period? Why are we concerned? The patients आए कि नहीं कोई बात नहीं पीरियड नहीं आए तो मैं बहुत खुश हूँ. क्यों नहीं आना चाहिए? क्यों? Because she is having anovulation. Anovulation means there's unopposed estrogen now acting on the endometrium. So she's at risk of which cancer? There's nothing to protect the endometrium. Yes, endometrial hyperplasia, endometrial cancer. So you have to give her progesterone at least every 3 months. So the aim is to let her get her period at least 4 cycles per year. She has to get to reduce the incidence of endometrial cancer. Okay? And that means every 3 months you have to give her progesterone for withdrawal bleeding. Okay, so this is what you do in the older woman. So this is what you need to understand when you get a question on management of PCOS. तीनों कैटेगरी ऑफ पेशेंट्स में पैरामाउंट ये है कि टेल हर टू डाइट, टेल हर टू एक्सरसाइज, टेल हर टू गेट इनटू अ नॉर्मल BMI, which I continuously try to do, but time ही नहीं मिलता, which I understand with all other women or girls who have PCOS, and counsel them of the risk of metabolic syndrome. ठीक है? If they're young, you do this, give them primarily OC pills. If they want to get pregnant, give them letrozole. Okay, and if they're older, make sure that they're getting their period at least every 3 months. Why don't we prescribe Litrosol to young girls? Because उनको pregnant थोड़ी कराना है हमने. Look here, she's not concerned about pregnancy. Why do you want to get her pregnant? Why do you want to induce ovulation if the aim is not pregnancy? Yes, for withdrawal, we give Meprate or either medroxyprogesterone acetate, that is Meprate, or norethistron acetate. Both are any progesterone basically. ठीक है, समझ आया? Last line. Every 3 months, give her progesterone for withdrawal bleeding. So she gets her period. Is it curable? Zen, I have had PCOS for most of my life, for half of my life, about. It goes off when I joined the gym. So how did I get pregnant? Both times I got pregnant without any drug. I went to the gym, good 3 months, exercised, got in shape, and I got pregnant. And so that's why I'm telling you this is very important to explain to the patient. You need to get an optimizer BMI and she will become okay. Okay, come back. Metformin is not advised as a primary drug just because it causes weight loss. It should be given only if there is associated insulin resistance. Otherwise, there is no point of giving metformin. Okay, coming to now a bit about IVF. And IVF is basically assisted reproductive technology. It is basically clinically and lab techniques done to achieve pregnancy. Now, in ART, we have two main things. One is IVF and one is ICSI. IVF is in vitro fertilization. I already told you what do. You give controlled ovarian hyperstimulation. You aspirate the oocytes. Letrozole, Anjali, we give usually 3 to 6 cycles. If she doesn't conceive in 3 to 6 cycles, we move on to the second line drug. Okay. Now, IVF, में क्या करते हैं? We give controlled ovarian hyperstimulation. Then once the oocytes are nice and big, we do what is called an oocyte aspiration. Okay, after giving the trigger. Once the oocytes are aspirated, the embryologist will do what is called as the main part, IVF, that is in vitro fertilization. What do? They take a petri dish, okay, and they add the sperm, millions of sperms. That means one ejaculate will have millions of sperms. तो sperms को add करते हैं with one oocyte and they wait for spontaneous fertilization to happen. But sometimes this is not done. Sometimes we do what is called as ICSI. What is ICSI? ICSI is intracytoplasmic sperm injection. So if there is severe oligospermia, what do you mean by severe oligospermia? If the count is less than 1 million per ml is the definition of severe oligospermia. Sometimes you have only one sperm. So even if you have only one sperm, okay, for example, a patient has obstructive azoospermia. Okay, that means there's an obstruction. There is an epididymal or some obstruction, and you do what is called a testicular sperm extraction. Okay, sometimes you do a TC or a TISA and you take out sperm from the testes directly using a needle. And sometimes you get only one sperm. तो अगर वन स्पर्म है तब भी पेशेंट प्रेग्नेंट हो सकता है. कैसे हो सकता है? फिर हम आईवीएफ नहीं करेंगे. यस, लाइक इन रेट्रोग्रेड एजैकुलेशन, तब हम आईवीएफ नहीं करेंगे. अगर आपको सिंगल स्पर्म मिला तो उस स्पर्म को वेस्ट नहीं करना. उस स्पर्म को आप एक इसमें डालोगे, नीडल में डालोगे और oocyte के अंदर you will inject it. So you are causing the fertilization to happen. So a single mature sperm is injected into a mature oocyte. So the fertilization, you're not leaving it to chance. Here, you're leaving it to chance in an IVF. In an ICSI, you are doing the fertilization. So it is preferred when there is male infertility or if IVF, ET means embryo transfer. The whole term is called IVF ET, in vitro fertilization and embryo transfer. अगर ये fail होता है या severe oligospermia है, it's better to do an intracytoplasmic sperm injection. Okay. Medico, there's no cutoff for sperm count for IVF, but to do an IVF, to allow this spontaneous fertilization to happen, the sperm should be more than 1 million per ml. ठीक है? If it's less than 1 million, we prefer to do an ICSI. So question कैसे आता है? ICSI का indication क्या है? ICSI का indication है severe oligospermia. ठीक है? Now, just a few lines about cryopreservation. What is cryopreservation? It is we can preserve or we can freeze certain things like the sperm. So you can freeze the sperm, you can freeze the oocytes. That means before fertilization, you can aspirate the oocytes and freeze them. You can cryopreserve embryos. Okay, this is usually the method of choice. So initially what was done was once you do the oocyte aspiration, you create the embryo. Once the embryo is formed, you directly do an embryo transfer. This is called a fresh embryo transfer. But nowadays, nobody does a fresh embryo transfer. What is done is that once suppose 3 or 4 embryos are formed, वो embryos को freeze कर देते हैं. And then after, in the next cycle or thereafter or many months later, then what is done? A frozen embryo transfer is done. The embryos are thawed and then the transfer is done. Why is that done? So frozen transfers, for reasons which even I need to read up in more detail, frozen embryo transfer has a higher success rate than fresh transfer. Okay, so that's why frozen transfers, frozen embryos are preferred. Also, apart from having a higher success rate, it is done whenever extra embryos are there, and it also reduces the risk of ovarian hyperstimulation syndrome. You can store them, shall be indefinitely, infinitely, you can store them, but certain laws are there now beyond. I'm not sure again because I'm not an IVF specialist. What is this new law now, the ART law, कब तक कहता है, but of course the patient has to pay the money and they can be stored indefinitely. Scientifically, they can be stored indefinitely. Okay, you can do as many IVF as you want till the patient gets pregnant. There's no limit on the number of IVFs. Okay. But usually the patient, at the end, there is a stop. Now, usually 3, 4, 5 IVFs ke baad, the patient also gets tired. Then obviously adoption is always an option for them. And most patients will not go beyond a certain number of IVFs. It's expensive. It adds to the psychological trauma. And then you can also cryopreserve ovarian tissue. This is usually done in women who have cancer before they are to undergo chemotherapy or radiotherapy, which the gonads are most sensitive to destruction by chemotherapy or radiotherapy. You can actually take out ovarian tissue and cryopreserve it. Okay, and then reimplant it after the chemo or radiation is over. But this is a very new thing. Okay, and it's not done in clinical settings, it's more of research purpose as of now. Somebody's asking if it's done in India. Yes, it's done, but only in research settings. So you will find it being done in many medical college setups or research setups. Now coming to complication of ART. So what are the complications of ART or IVF? OHSS, this is most commonly asked in the exam. We've discussed these. Now multiple pregnancy hota hai, ectopic pregnancy hota hai. Heterotopic kya hota hai? Heterotopic, where you have an intrauterine plus an ectopic, because the embryo transfer which you're doing is a blind procedure. You don't know where the embryo will go. Okay, one you can add here is pregnancy complications like placenta previa. Remember, I told you it can go and implant in the lower uterine segment. Now, congenital malformations is plus minus. Some evidence says yes, some says no. If at all, the risk of hypospadias in male fetuses is increased. Risk of cancer, again, this is a theoretical risk, especially with multiple follicles when they formed. So as I said, more than 6 cycles are usually not advisable. Okay, and of course the psychological, the mental health and the stress and all of this. Okay. Now, a little bit about OHSS. OHSS is ovarian hyperstimulation syndrome. It is basically a fluid and electrolyte imbalance which happens because of enlarged hyperstimulated ovaries. Okay, so it's an imbalance, and one of the main factors that has been found to be contributory towards this syndrome is high levels of beta HCG. Okay, and this happens when especially you use, if the patient becomes pregnant, of course HCG levels high honge, but we're talking about before she gets pregnant. So the trigger should not be, so the common question that comes is, if the woman is at risk of OHSS, what should we do? We should not use HCG as the trigger. What should we use instead then? We can use GnRH agonist. Okay, and a common substitute is a drug called leuprolide, which is a GnRH agonist. It is used in place of HCG as the trigger. Okay, so that's an important question that comes. Another important question that comes are, what are the risk factors for OHSS? So if the ovaries are big from the beginning, like in PCOS, but remember PCOS mein girls are fatter. This complication is typically seen in thin PCOS girls. Lean PCOS, that means low BMI. So those girls who are very thin and have PCOS are at a higher risk of developing OHSS. Those girls who have a higher estradiol level during the, so when we are doing the controlled ovarian hyperstimulation, we monitor estradiol levels. If they go more than 4,000, they're at a higher risk of developing PCOS. Those with a higher AMH level, okay, PCOS and a high AMH go hand in hand. Those with a previous history of OHSS, these women are at a higher risk of developing OHSS. Leuprolide we give in place of HCG as a trigger. Normally we give HCG as trigger for both clomiphene, letrozole, even in IVF cycles. But if the woman is at risk of developing OHSS, we should not give HCG. It's going to worsen the whole situation. We should give leuprolide. Leuprolide also is a drug which can mimic the action of LH. Okay, and acts as a trigger. So you have mild OHSS, moderate OHSS, both can be managed in the OPD setting. They don't need admission. But once she has severe OHSS, that means she has ascites, pleural effusion, she's going into renal failure, the hematocrit goes up, electrolyte imbalance worsens, there is hypoproteinemia. Okay, then she requires admission. Okay, and critical OHSS, she's at a higher risk of thromboembolism, DVT, and ARDS. So such patients require critical care support, and usually they require supportive care in the ICU. Okay. How to know? High estradiol levels is a very important risk factor. Okay, and of course the warning signs: abdominal bloating, mild pain, ovarian size, large ovarian size. If the patient has any of these complaints, mainly pain, abdomen, nausea, vomiting, she is to report immediately. Okay. And lastly, before we finish this topic, how do you prevent OHSS? So one is you can avoid HCG. So give leuprolide instead as the trigger. You can cancel the cycle. If you feel that the risk is too much, just stop the cycle. Don't do anything. Especially don't do the embryo transfer. अगर आपने embryo transfer कर दिया and she becomes pregnant, the HCG levels are going to rise even further and it will worsen the whole scenario. What else can you do? You can avoid HCG, give leuprolide, or delay leuprolide also. Delay the trigger. Don't give it immediately, give it after a few days. Okay, what else can you do? There are certain drugs which are known to reduce the incidence of OHSS. One is cabergoline. कहाँ पे देते हैं हम usually cabergoline? Where do we give cabergoline? It's a drug we use for hyperprolactinemia, है ना? But in gynae, we use it for many. Cancel the cycle means stop everything. कुछ मत करो. Don't just stop all the stimulation. Don't give the trigger. Let the ovaries come back to normal by themselves. Yes, it is also given in endometriosis, very good. And it is also being started to be given in medical management of fibroids also. So four uses of cabergoline. One is prevention of OHSS, prolactin, hyperprolactinemia, endometriosis, and fibroid. Okay. What else can we do to prevent OHSS? One is we can give uh, 1 second. So yeah, albumin. Albumin is available as intravenous infusion because hypoproteinemia is another feature of OHSS. So by giving IV infusion albumin, this also. Okay. To correct, Shubham. So that is, yeah, correct. So I'll write what his Shubham has given one more indication of using cabergoline. That is if you want to suppress lactation. Okay, a patient who's had an intrauterine death, you don't want her to have breast milk, so you to give it's given to suppress lactation. Okay, so these are ways to prevent ovarian hyperstimulation syndrome. Now coming to questions, ICSI is useful in, yes, oligospermia. In fact, severe oligospermia when the count is less than 1 million per ml is when you want to do a intracytoplasmic sperm injection. So severe oligospermia, which is incorrect regarding clomiphene citrate. It causes monofollicular development. No, it causes multifollicular development. It has two components. Remember, it has two components, N-clomiphene and zoo-clomiphene. The N-clomiphene is more potent. Okay, there's increased risk of multiple pregnancy. Ovulation will occur in 80% of patients. Okay. A couple who is unable to conceive undergoes laparoscopy and chromotubation. This is the image. So the fallopian tube is not seen here. Huh? This is, so what are you seeing here? You're seeing these black, these are called as powder burn lesions. ये पता नहीं किस part of the abdomen है, but ये basically मतलब आपको समझ नहीं आएगा, but this is basically the round ligament. Round ligament के ऊपर you see these blackish or powder burn lesions, which are typically seen in endometriosis. Chocolate cyst is also endometriosis, but this is not chocolate cyst. Chocolate cyst is a large ovarian cyst. This is endometriotic spots on some part of the peritoneum. Okay. All are complications of ART except OHSS, yes. Heterotopic, yes. Multiple pregnancy, yes. FGR indirectly, yes, but not a direct complication. Like if there's twin pregnancy or placenta previa, you may find FGR, but not a direct complication. A 24-year-old woman who has Mullerian agenesis wants to know her fertility options, which is not an option. So she has Mullerian agenesis. You can advise her adoption. You can advise her surrogacy. You can advise her transplant. What is GIFT? GIFT was an old method of IVF in the beginning when IVF first came into being. This is called as gamete intrafallopian transfer. So what was done is that gamete means the embryo was transferred, the oocyte or the sperm was directly injected inside the fallopian tube, which is a very indirect way of getting her pregnant, है ना? So that is not possible in a patient who doesn't have a fallopian tube. And gift and zift, the other method was zift. Zift is when you put the embryo, zygote intrafallopian transfer inside the fallopian tube. So putting the sperm or the embryo directly inside the fallopian tube is no longer done also now. So this is the answer. 25-year-old, so this was the evening session of this year's NEET PG. 25-year-old woman with primary infertility is found to have bilateral tubal block on HSG. The next best step is laparoscopic chromotubation. Okay, you might think IVF, yes, but no, we always counsel the patient, पहले confirm तो कर लो, उसके बाद फिर देखा जाएगा, ठीक है? So that ends the topic on infertility. Now, very small topic, just one table on infections of the vagina. It's a very high yield area. No, we can't stop Dhanush now. 12 o'clock स्टॉप करेंगे, ठीक है, 12 बजे तक जितना टॉपिक हो जाता है, ठीक है. नाउ so what is the normal vaginal discharge? Before you know what is a vaginal infection, we first talk about what is normal vaginal discharge. Normal vaginal discharge is that how do you describe it? So every woman will have a normal amount of vaginal discharge. It could be excessive at times. It is excessive in certain times of the menstrual cycle, especially around ovulation, premenstrual it increases, and during pregnancy it will increase. But the description is it is clear discharge, okay, clear or whitish discharge, and very importantly it can stain the undergarments, okay. Why does it stain the undergarments? Because it is acidic. Okay, so it causes bleaching of the undergarments, and that's an important normal finding. Okay, and this came as a question, that's why I'm stressing on it. It is a normal finding. Now, the vaginal pH depends on the estrogen levels. The higher the estrogen, the more acidic the pH. In a newborn, because this newborn is under the influence of, for a few days to weeks, she is under the influence of maternal estrogen. So थोड़ा बहुत acidic pH होता है around 5 to 6 के बीच में, ठीक है, 5.6 is the exact value. Children, there is no estrogen, so it's more of an alkaline pH. Once the girl attains puberty, it starts becoming acidic. Pregnancy, it is the most acidic time. Okay, it reaches even 3 to 3.5 maximum acidic. Usually, it's around 4 during puberty and during reproductive age group. And menopause is again when there's no estrogen, so it goes high. So it depends on the estrogen levels. Okay. Now, coming to the different types of infections. So there are basically three types of infections in the vagina. One is bacterial vaginosis, one is Trichomonas vaginalis, and one is candidiasis. And इस पे question usually आता ही आता है. It's a very simple topic. Bacterial vaginosis is not caused by any specific one organism. It is caused by a change in the normal bacteria of the vagina. So the normal bacteria the vagina has plenty of lactobacilli. Now, if there is a reduction in normal lactobacilli and increase in other types of organisms, then it leads to bacterial vaginosis. Now, what is the typical feature? How will this patient present? She's going to present to you with grayish white, thin, same consistency wala discharge, which coats the walls of the vagina. It will be foul. So she'll have a foul smelling whitish, grayish white discharge but she won't have any other symptom. Koi pruritus, itching, urinary symptom, nothing else. Just foul smelling discharge. And when you examine her, the cervix and the vagina will look normal, except for the discharge, आपको कोई erythema, redness नहीं दिखेगा. When you do a pH, so we have these gloves which we keep in the OPD, which have pH indicators. ठीक है, on the tip. So when we examine her, do a PV, and then the tip has the pH indicator. It changes color if it is alkaline. ठीक है, if it's acidic, actually it changes color. तो ये अगर pH more than 4.5 है, so if it's an alkaline, if it's going towards the alkaline side, that means it is a change in the normal pH is seen in bacterial vaginosis. Now, what is the way to diagnose BV? Okay, so so there are two ways to diagnose BV. One is the microbiologists, what they do. The microbiologists use what is called the Nugent's criteria. Now, Nugent's criteria is supposed to be the gold standard, but it is what the microbiology people do. For every patient, we will not be sending a smear for checking. We do what is called the AMSELS. This is more of a clinical criteria. ठीक है, न्यूगन स्कोरिंग जो है, ये क्वेश्चन आया है इन दिस नीट पीजी इवनिंग सेशन. ठीक है, the question was Nugent scoring is for diagnosis of, and many people didn't know this. The answer is bacterial vaginosis. ठीक है, What is Nugent scoring? I also just put up an example of what is done, although I'm sure micro mein karaya hoga because it came as a question this time. So the microbiologist will sit and look at the slide and count the number of bacteria. ठीक है, कौन से bacteria count करता है? The normal lactobacilli, and then they count Gardnerella and Mobilingus. ये normally कम होने चाहिए और ये ज़्यादा होना चाहिए. ठीक है, so a score of 0 is given if there is a lot of lactobacilli and no Gardnerella Mobilingus. But the score keeps increasing as the lactobacilli increases, and you can see these are increasing. ठीक है, समझ आ गया? So you don't have to learn the scoring. What's important to understand is you basically count the 3 bacteria, and the lesser the number of lactobacilli, the higher the score goes up. ठीक है? So 0 to 3 is normal flora. 4 to 6 is intermediate, and 7 to 10 is a score of bacterial vaginosis. This is something which is new, so I put it up here. Most of us know the other criteria which is commonly asked because that's what we actually do in clinical practice. We do the AMCELS criteria. AMCEL criteria क्या कहता है कि 3 out of 4 होने चाहिए. 3 out of 4. You won't find this slide in your workbook because I put this today. Okay. So 3 out of 4 criteria होने चाहिए. First is clue cells. You make a wet smear, a saline drop you put on the discharge and you check under the microscope. Second is the whiff test. You add potassium hydroxide, put a drop of potassium hydroxide on the slide, and you have this sudden fishy odor which comes out. Okay. Third is pH more than 4.5, and 4 is this discharge. ठीक है? So any 3 of these 4, if it's there, it is AMCELS criteria. Now, what are these clue cells? Clue cells are cells which appear. Oh, the slide has this. I think workbook usme hoga na slide of clue cells. Is it there? Here is the Nugent scoring वाला slide. Clue cells वाला slide मेरा गायब हो गया है ना. तो clue cells में क्या होता है? So normally you see when you make a vaginal smear का slide, you see large polygonal vaginal epithelial cells which look like this. ठीक है? This is normal. You'll see nice big cells. ठीक है? Clue cells में क्या होता है? Clue cells में these vaginal epithelial cells get coated with the Gardnerella and the Mobilingus. ठीक है? So the edges are no longer smooth like this. They become blurry. And these are called as clue cells. And they're typically seen in bacterial vaginosis. ठीक है? So BV में you'll have the clue cells, and that's one part of AMCELS criteria. So AMCEL criteria जरूरी है, पता होना चाहिए. और अब Nugent scoring भी you should know that it is for bacterial vaginosis, and the better one is actually Nugent scoring because you're having a very objective assessment. You are actually counting the number of lactobacilli, है ना? So it's of course the better way. It's the gold standard. Now, what is the treatment? Just add here, the treatment is not mentioned. Here you're going to give the patient metronidazole. Metronidazole is given either as a vaginal tablet or an oral tablet. That is the treatment of choice. Next is trichomoniasis, which is caused by the protozoal organism Trichomonas vaginalis. And remember, this is a sexually transmitted disease. BV is not sexually transmitted, although it increases the risk of STDs, but it by itself is not an STD. Candidiasis is not an STD. Trichomoniasis is an STD. Okay, so that means what? That means you have to treat the partner also. Okay, how will this patient present? She's going to present with yellowish, greenish, frothy, foul-smelling discharge, and she will be very uncomfortable. She'll be having a lot of itching, a lot of dysuria. So urinary symptoms, itching, and when you examine her, you find that the vagina and the cervix is studded with this one with small red spots. This is called as strawberry vagina, also called as colpitis macularis. Okay, the pH is again high, and on examination you find these motile organisms. Okay, so you'll actually see the flagellated organism here. So you'll have this nice organism with flagella seen on the smear. Okay. Treatment again is metronidazole, but here you're going to treat both the partners. So usually BV and trichomonas coexist. Okay, they coexist because trichomoniasis is going to change the pH, and that will predispose the woman to have BV. And if the woman has BV, it changes the pH, it predisposes her, if she's sexually active, to develop trichomoniasis. So usually both coexist together. Then we have candidiasis. Candidiasis is a fungal infection. The patient is going to have this typical thick curd-like discharge. Okay, but there's no foul smelling. So there's no smell, but she will have intense itching and she'll have urinary symptoms. Okay, so इसमें typically there is no foul smell. pH is going to be acidic. So here you find an acidic environment, and that's why it's more common in pregnancy. So it's more common in pregnancy because pregnancy may the pH goes down. Erythema, so you're going to find a red looking, angry looking vagina here, and when you do the smear you're going to find pseudo hyphae or spores. Treatment of candidiasis, you're going to give antifungals. Commonly we give vaginal clotrimazole tablets. You can even give oral fluconazole. Okay, so fluconazole oral or vaginal clotrimazole. Okay, it is also more common in women who are immunocompromised, like those who have HIV positive, or those who are on corticosteroids, or those on oral contraceptive pills also, because the pH is reduced. Okay. Yes, that's why Shalby, the kit number 2, which is for vaginitis, contains secnidazole and fluconazole because it covers all the 3 infections then. Okay. Syndromic management. For how many days? Clotrimazole, if you're giving vaginally, we give it for usually 6 days. Fluconazole is a single oral tablet of 150 milligram. Yes, pregnancy mein you can't give prolonged fluconazole, but one single tablet will not cause any harm. Okay, now coming to fibroids. Okay, so fibroids is a little long topic, but I want to finish this topic and then we stop the class. Okay, एक major benign gynae disorder. So the plan was I would finish half the benign gynae disorders today and the remaining tomorrow, but let's finish fibroids. So this will complete a huge bulk of the topic. Okay. Complicated candidiasis, Saransh, not very important, but complicated candidiasis means if she's had more than 4 episodes per year, in a year, then it is complicated candidiasis, and then she requires prolonged fluconazole therapy. So we give weekly therapy for around 6 weeks, but it's not important. Now coming to fibroids. Fibroids क्या होता है? Fibroids are the most common benign tumor of the uterus. Okay, we will finish this topic and then we will stop. It's a very interesting topic. So if you show some interest, I will also be interested in teaching. It's a big topic, Aditya. I know 10 minute में नहीं हो सकता, but ये करके ही खत्म करते हैं. Half an hour, 30 minutes. 12:20 पे I will get you guys free. ठीक है? So it is the most common benign tumor of the uterus. ठीक है? And this is how the gross specimen will appear. So you have these well circumscribed lesions. So well circumscribed hai, nice big lesions or small lesions, but you can make out they're whitish in color and they nicely have a nice outline. Okay. Now the basic types of fibroids are 3. You have a submucosal fibroid, which is within the cavity. We have an intramural fibroid, which is in the muscle. And we have a subserosal fibroid, which is on the outer surface, on the serosal surface. So the basic classification is submucosal, intramural or intramyometrial, and subserosal. ठीक है, तो ये 3 basic classification है. But to complicate things a bit further, the FIGO is Federation of International Gynecologists and Obstetricians. They said थोड़ा सा हम complicate करते हैं, ठीक है? So but I want you to just take a plain paper if you're writing, or if you're on your iPads, just take a plain page and do the classification with me. आज तक पूछा नहीं है, but it's something which I feel is very probable can be asked. So just draw the uterus with me and do the classification with me. You will understand this without having to mug it up. ठीक है, so let's draw the uterus. ठीक है, and let's start the classification. So Figo का ये वाला classification says fibroids can be of two types only. One is submucosal and O. O means other. ठीक है, so basic classification is two, submucosal and other. ठीक है, so let's start drawing. The first one is तनुष, लास्ट टॉपिक प्रॉमिस्ड, इसके बाद परेशान नहीं करूंगी, आप यूट्रस ड्रॉ करो. बी विद मी, आई विल मेक यू अंडरस्टैंड इवन इफ यू आर वेरी टायर्ड. ठीक है, ठीक है, सो लेट्स जस्ट डू दिस, ड्रॉ दिस विद मी. ओके, बना लिया, बनाओ. ठीक है, ड्रॉ द यूट्रस. द फर्स्ट फाइब्रॉइड इज दिस वन. ठीक है, दिस फाइब्रॉइड इज टाइप 0. ठीक है, type 0 basically means a pedunculated submucosal fibroid. तो type 0 लिखो यहाँ पे, type 0 है pedunculated submucosal fibroid. Then the next one is this one. ये क्या है? ये है type 1. Type 1 is a fibroid which has more than 50% component submucosal and less than 50% component is intramural. ठीक है, then we have a type 2 fibroid. Type 2 fibroid is when more than 50% is intramural and less than 50% is submucosal. So in submucosal we have three types, 0, 1 and 2. Now suppose I want to remove this fibroid. ठीक है, suppose, and I told you before, submucosal fibroids can cause infertility. So if I have a patient with a submucosal fibroid who has infertility, she has come to me for a myomectomy. Myomectomy is the surgery which is for removal of fibroid. So basically, when I'm removing only the fibroid, it's called a myomectomy. Now tell me, what is the best way to approach a type 0 fibroid? Is it by laparoscopy or laparotomy, or is it by hysteroscopy? It is hysteroscopy, है ना? So if you want to remove a type 0 or a type 1 fibroid, the treatment of choice is a hysteroscopic myomectomy. ठीक है? For all other fibroids, if you want to do a myomectomy, it has to be by the abdominal approach, that is either a laparoscopy or a laparotomy. ठीक है, पेट से जाना है, आप नीचे से, even a type 2, because it's very deeply embedded, you can't take it out hysteroscopically, you will get stuck. So only type 0 and type 1 you can do hysteroscopic myomectomy if you want to do a myomectomy. Now let's continue the classification. Now we go to the other types. So this is a type 3 fibroid. Type 3 fibroid basically means intramural hai, but it is touching the endometrium. It is not indenting, it's just touching the endometrium. This is a type 4 fibroid. It is completely intramural. It is neither touching the cavity nor is it touching the outer surface. This is a type 5 fibroid. ठीक है, जिसमें, I'll draw it again. This is a type 5 fibroid. That is more than 50% is intramural, less than 50% is subserous. This is a type 6 fibroid. More than 50% is subserous, less than 50% is intramural. This is a type 7 fibroid. Type 7 fibroid क्या है? It is pedunculated subserosal. So you have 3, 4, 5, 6 and 7 which are intramural or subserous. ठीक है, if you want to classify, 3 and 4 are intramural, 5, 6, 7 are ones which have subserosal component. ठीक है, then you have one more type of fibroid, that is a type 8 fibroid. Type 8 fibroid is one which is in an unusual location, like a cervical fibroid or a broad ligament fibroid or some other unusual location. Okay, so you have in others, you have 3, 4, 5, 6, 7, and you have 8. Okay. Now, there is another type of fibroid called a hybrid fibroid. What is a hybrid fibroid? Suppose you have a fibroid with all three components, subserous, intramural, and submucosal. It is called a hybrid fibroid. तो कभी कभी बहुत बड़े बड़े fibroids होते हैं which have components in all three regions. It's called a hybrid fibroid. ठीक है, so this is what you should know, and this is the new classification. If you've done this with me, you will never forget. Just start from inside and go outside, and you have the different types of fibroids 1 to 0 to 7. Type 8 is unusual, and hybrid is all. Hybrid is one which has all the components. It's a huge fibroid encompassing from subserous to submucous. The तीनों components are there in a hybrid fibroid. Okay, so this is what you should know. Now coming to another important topic, fibroids tend to undergo degeneration. That means some अंदर कुछ वो हो रहा है, some change in tissue is happening. The most common degeneration is not red. Red is the one जो most commonly asked in exam है. Most commonly जो patient में हो रहा है, that is hyaline degeneration. ठीक है? And the most rare, or one which we usually, so when a patient comes to us and asks us कि ये cancer हो सकता है fibroid, हम बोलते हैं नहीं हो सकता है, because the risk of malignancy is 0.01%. That is leiomyosarcoma. ऐसा नहीं है कि बिल्कुल भी risk नहीं है, but the risk is very very less. So very rare chance of it becoming a leiomyosarcoma. That is malignant degeneration or malignant transformation. ठीक है. The most common in pregnancy, however, is red degeneration, and the most commonly asked in the exam is red degeneration. ठीक है. Now, what is this red degeneration? How will this patient present? So the patient usually presents when in the second trimester of pregnancy. Usually she's a known case of fibroid and she's pregnant. Okay, and she comes with main complaints of what? Main complaints of pain. Okay, she may have fever. Okay, but her main complaint is going to be pain, and she's going to be tender. There'll be tenderness over the uterus, especially over the area of the fibroid. Okay, the question that comes here is, and if you examine her, you'll find there's a raised TLC, but this is not an infective degeneration. It's basically an aseptic thrombosis which is happening. It is a aseptic thrombosis which is happening, and why this happens nobody knows, but it happens in pregnancy. It is also can happen in the puerperium. It also can happen if a woman has been taking contraceptive pills. This is, however, rare. Most common presentation is in pregnancy. Now, the question that comes in the exam is treatment. What will you do? Like in this patient, ये तो hysterectomy किया हुआ है. Will you remove the uterus for this? Will you do any sort of surgery, myomectomy, hysterectomy, aseptic thrombosis? Will you do any type of surgery here? No. So it is only conservative management. You will admit her, you will hydrate her, you will advise her rest, and you will give her painkillers. You will give her analgesics. You will not do an MTP, you will not do a myomectomy, you will not do a hysterectomy. तो कुछ भी आप interventional नहीं करोगे. Hydration has been found to reduce her symptoms. So hydration, rest, analgesia, majority of times they will settle or subside on their own. It may take a few days, but it settles down. ठीक है, तो कुछ करना नहीं है. Now coming to how does the patient with fibroid present? Majority are asymptomatic. They have no symptoms whatsoever, and if they have no symptoms, no treatment required. Okay, irrespective of size. Even if they are very large fibroids, you don't have to treat them. Okay, they are incidental. They are just a finding on the ultrasound. Most of the time, the medicine people will call us and say ki fibroid IR scan pe come and see the patient. They'll give a gynae consultation for a fibroid which is asymptomatic. So whoever takes up medicine na, after this exam, please don't give gynae people consultation for asymptomatic fibroids. ये याद रखना है, ठीक है? So asymptomatic fibroid, nothing to do. Fibroids there are many reasons why they happen. Okay, but we're not going to go into too much detail. They are definitely hyper-estrogenic. So estrogen जिसका ज़्यादा है, fibroid का incidence ज़्यादा होता है. Then there are genetic causes and many other causes. ठीक है? So no treatment required irrespective of the size. Now, one of the most common complaints of symptomatic fibroid is a menstrual abnormality, and the most common menstrual abnormality is menorrhagia. अब पहले हम menorrhagia कहते थे, अब हम menorrhagia has been replaced by the term heavy menstrual bleeding. Now we don't call it menorrhagia, we call it HMB. We'll be discussing these new definitions tomorrow. ठीक है, menorrhagia means heavy bleeding in a regular cycle. So she'll be bleeding every month on time, but she has heavy bleeding. ठीक है, that's one of the most common symptoms. Why does she have menorrhagia? Because these fibroids are very vascular and they have vascularity all around. So there's increased vascularity of the uterus. Okay, and the endometrium also, you can see the endometrial surface area has increased. So if it's a fibroid distorting the cavity, it's going to have a higher endometrial surface area. So more endometrium gets shed off, so more bleeding. Now fibroids are hyperestrogenic states. Okay, fibroids are hyperestrogenic states, and these um, so hyperestrogenic states tend to coexist. What are the other hyperestrogenic states that you know of? One is endometrial hyperplasia. So they may be associated endometrial hyperplasia or endometrial cancer along with the fibroid. Okay, and that can lead to also to menorrhagia. Also, there is dysfunctional uterine contractions. So one mechanism of why the period stops is the uterus contracts and the period will stop. But if the uterus is not contracting properly, the patient keeps bleeding. So these are the reasons why the patient has menorrhagia. Sometimes there is a different kind of bleeding. There is intermenstrual bleeding. Which kind of fibroid from type 0 to 7 will lead to intermenstrual bleeding? That is bleeding in between her regular menstrual cycle. She is having bleeding. Which one? Which submucosal? Type 0. Very good. So a pedunculated submucosal fibroid, a type 0 fibroid, especially if it's a one with a big fibroid with a large pedicle, it is likely to cause intermenstrual bleeding. That means a fibroid like this. Okay, so its surface tends to get eroded, okay, and or infected, and it tends to bleed. Menstrual bleeding is the second type of menstrual abnormality. This is a pedunculated submucosal fibroid. This is seen on hysteroscopy. This is a hysteroscopic picture of a pedunculated type 0 fibroid. Okay. Now, other complaint which the patient can have is dysmenorrhea. The patient will typically complain of congestive type of dysmenorrhea. So there are two types of dysmenorrhea, spasmodic and congestive. Spasmodic is primary dysmenorrhea, congestive is secondary dysmenorrhea, that is secondary to a pathology. Primary dysmenorrhea, that is spasmodic, is the typical dysmenorrhea which most girls will have. That is because there's no pathology associated. Okay, and this is one which begins a few hours before the periods and settles within a few hours once the periods begin. But congestive dysmenorrhea is secondary to a pathology like fibroids, like adenomyosis, like endometriosis. Okay, so there will be a pathology here. Okay. पेडंक्यूलेटेड सबम्यूकोसल हो सकता है खुशी, पेडंक्यूलेटेड सबसीरोसल हो सकता है. पेडंक्यूलेटेड सबसीरोसल क्या प्रॉब्लम क्रिएट करेगा? इफ इट्स अ पेडंक्यूलेटेड submucosal, it will cause intermenstrual bleeding. If it's a pedunculated subserosal, this can undergo torsion. Somebody had written this can undergo torsion on the pedicle. But again, it's a very rare scenario. It's not commonly seen, but this is what it can cause. Okay. Now coming to other complaints, infertility. Infertility, I told you this before, occurs in only two types of fibroids. Either वो submucosal है, ठीक है, या large intramural है. Now, so two types of fibroids which require treatment because they can cause infertility is either is all submucosal fibroids need to be removed if the patient has infertility, or any large intramural. And when I say large intramural, I basically mean any fibroid more than 5 centimeter, which is intramural. Yes, hybrid also if it's large, Aditya, and hybrid will have submucosal component, तो उसको निकालना ही निकालना है. Or fibroid which is distorting the cavity. So large intramural means a fibroid which is more than 5 centimeters or which is distorting the cavity. Subfertility is the new name for infertility. तो पुराने books में they will write infertility, but it is has a negative connotation to it. It implies कि आप कभी pregnant हो ही नहीं सकते हो. अगर आप patient को बोलते हो आप infertile हो, मतलब वो कभी fertile हो ही नहीं सकती. That is the meaning it gives ना. तो सब fertility का मतलब है कि all women are fertile, some are less than others. So it's a term which has better what you say, it sounds better to the patient. ठीक है. Coming to other symptoms. So the patient may present, if it's a very large fibroid, she may present with a mass per abdomen. If it's towards the posterior part, she may have constipation. If it is towards the anterior part, she may have retention of urine or frequency of urine, depending on where it is pressing upon. Okay, so urinary symptoms, constipation, abdominal mass, these are other symptoms that the patient can present with. Other symptom the patient can have is an adverse pregnancy outcome. So basically, what does the pregnancy do to the fibroid? What does the pregnancy do to the fibroid? We have discussed this. It's going to make the fibroid undergo red degeneration. And what does the fibroid do to the pregnancy? Starting from the first trimester, it can cause recurrent pregnancy losses, especially again if they're submucosal fibroids or large fibroids distorting the cavity. They can cause, yes, preterm labor. They can cause PPROM. They can even cause abruptio placentae if the placenta is implanted over a fibroid. They can cause IUGR because the space may be less for the baby to grow. They can cause malpresentations. Okay, they can cause in labor, they can cause prolonged labor, obstructed labor. They can cause postpartum hemorrhage. They can cause retained placenta. So basically, they can affect the pregnancy in many ways. So start, yes, subinvolution. Why prompt PPROM? Because a large fibroid is part of the uterus. So it can lead to a weakening of the membrane, or as part of preterm labor, it can stimulate contractions and lead to rupture of membranes. ठीक है, oligopoly इसमें नहीं होता है. So pregnancy loss, preterm, PPROM, antepartum hemorrhage में mainly abruption, not usually placenta previa. ठीक है, IUGR, malpresentation, prolonged obstructed labor, postpartum hemorrhage, retained placenta. ठीक है, so start from the first trimester, and so many complications it can cause in pregnancy. So again, it depends on the size and where the fibroid is. Okay, it's not necessary कि fibroids will cause all this. Some fibroids are completely asymptomatic, but some fibroids do cause problems. ठीक है. Now, so those are the symptoms. Now, what are the signs? Or when you examine a patient, what do you feel? So if it's a very large fibroid, it may be palpable on abdominal examination. So on abdominal exam, what will you feel? You'll find a regular or irregular mass. Okay, it's regular. If it's a single fibroid, it's regular. If it's multiple fibroids, it will be irregular. Okay, usually the margins are smooth, the consistency is firm. They, if they're not undergoing any degeneration, they are usually non-tender and they are usually mobile. The lower border is not going to be felt because it is arising from the uterus. Now, a common question they ask in clinical viva, which can be converted to a MCQ kind of question, is how will you differentiate an abdominal mass or uterine mass from an ovarian mass on examination? Okay, so suppose you have a fibroid, okay, say a large fibroid here, which you're able to palpate per abdomen versus an ovarian mass. Okay, and let's say the ovarian mass is somewhere here, large ovarian mass is here, which you're also able to palpate per abdomen. Okay, tender tab hoga if it's undergoing some degeneration, otherwise fibroids are not usually tender. Okay, so how will you differentiate between an ovarian and a uterine mass is a common question. So, ovarian mass may also be mobile. Now, look at the examination being done here. This is a bimanual examination this person is doing. One hand on the abdomen, two fingers in the vagina. So, what they're going to do is you're going to move the mass with the abdominal hand, and with the vaginal hand, you're going to feel if this mass is moving. What is this test called? This test is called transmitted mobility. So what is being shown here is transmitted mobility. That means on moving the abdominal hand, the mass abdominally, does the cervix move or not? If transmitted mobility is positive, what does this mean? That means on moving the mass, you're able to feel the cervix move. This means, is the mass arising from the uterus or the ovary? It's arising from the uterus. It is part of the uterus. That's why on moving the mass, the cervix is moving. है ना? So, transmitted mobility is going to be positive or going to be present in a fibroid. It's going to be absent in any other mass, even ovarian masses. But there are certain exceptions to this rule. What is the exception to the rule? That means where, in which kind of fibroid will transmitted mobility be absent? That can come as a question. Small to palpable bhi nahi hoga na per abdomen. We're talking about a mass which is palpable per abdomen. Yes, a broad ligament or a pedunculated subserosal fibroid. So if you have a fibroid which is pedunculated like this, ऐसा fibroid है, ठीक है? It's having a long pedicle or it's in an unusual location away from the uterus like the broad ligament. A pedunculated subserosal fibroid, transmitted mobility is going to be absent. So even if it's arising from the uterus, mobility is going to be absent because it has a long pedicle. Okay. Also, the other scenario, in which situation will an ovarian mass have transmitted mobility? So what is the exception to the ovarian mass? Is a pedunculated uterine fibroid or a broad ligament fibroid, and an exception to the rule of ovarian mass which has stuck. Sorry, can you hear me now? My phone got switched off again. Came now? Can you hear me now? Okay. So ovarian mass ka exception to the rule where an ovarian mass can have transmitted mobility is a malignant ovarian lesion stuck to the uterus. So any lesion stuck to the uterus will have transmitted mobility. So exceptions to the rule for the uterus wala is a large pedunculated fibroid. An exception to the rule for the ovarian wala is a malignant lesion stuck or adherent to the uterus. Okay. Now coming to investigations. What's the investigation of choice for a fibroid? It is an ultrasound investigation of choice. It's lagging. Just give me 2 minutes. मैं phone से connect कर लेती हूँ. Phone मेरा बंद हो गया था. I didn't realize. So investigation of choice is an ultrasound. You can see in this ultrasound you have clear, well circumscribed lesions, है ना? So when you have these nice well circumscribed alag dikh rahe hain, this is, you can clearly see this is a fibroid. And the ultrasound, remember, is the investigation of choice. Other than ultrasound, so this is another ultrasound. Can you see the fibroid here? This is a transvaginal scan. You can see this is the uterus. This is the endometrium. Okay. And can you see this lesion here? So what kind of fibroid is this, if at all? कौन सा type of fibroid है? This is subserosal fibroid. Okay, most likely a type 6 fibroid. Okay, so this is a subserosal fibroid. Type 7 will be pedunculated. This is attached to the uterus. This is a type 6 subserosal fibroid. This is an MRI. You can see L written here. This whole thing is the uterus. यहाँ पे white is the endometrial cavity. This white here is the bladder. Okay, this is the rectum behind, and this large thing is the fibroid. But MRI we don't usually routinely use for diagnosing fibroids. MRI is useful in a patient who has multiple uterine fibroids and you are planning for her a myomectomy. Now, a woman with multiple fibroids, a myomectomy will involve a lot of planning because you need to know beforehand कि कहाँ fibroid है. So you can plan your incisions in such a way that you have minimum incisions on the uterus. This is called as mapping. Mapping of the fibroids prior to doing a myomectomy in a patient who has multiple fibroids. So basically planning your surgery so you can give minimal incisions on the uterus through which you can take out maximum number of fibroids. Now somebody was asking me about this in infertility. What is SIS? Saline infusion sonography, also called as saline salpingography. जैसे HSG है ना, this is SSG, saline salpingography, also called as saline infusion sonography. What is this done? This is both a test of tubal patency. It is also a test of looking inside the uterus. So any intracavitary lesion we can see. It is an ultrasound test. So sonography है ना, saline sonography. तो ultrasound में हम क्या करते हैं? हम using a Leach Wilkinson or a Rubens, we inject saline. So we are injecting saline into the cervix, and at the same time we are doing an ultrasound. The saline is going to delineate the cavity. Okay, and I told you anything black on ultrasound is fluid. Okay, so you can see it's delineated the cavity, and you can see a nice submucosal lesion or a filling defect inside the intrauterine lesion. So you're able to see intracavitary lesions like a submucosal fibroid, like a endometrial polyp. These will nicely be seen. And how can we make out tubal patency? तो ये fluid कहाँ जाएगा? ये fluid फिर tubes में जाएगा. Usually the tubes are very flimsy. You will not be able to see it passing through the tubes, but you will see that in the pouch of Douglas, fluid has collected. That means black. It will appear black in the pouch of Douglas behind the uterus. So if you see fluid in the pouch of Douglas during the procedure or after the procedure, you know for sure that at least one tube is patent. At least one tube is patent. So you usually in an SSG का disadvantage का ये है कि you usually don't see the tubes, the fluid going through the tube. Sometimes you can see, but not necessarily. But once the fluid is seen in the pouch of Douglas, you know कि fluid कहीं से तो आया है. At least एक tube हमारा patent है. ठीक है. So SIS or SSG is a good test for both intracavitary lesions and looking at tubal patency. ठीक है, clear? So this can come as an image-based question. Now, another common question they asked, which has come in the exam is, so you've seen an intracavitary lesion. Now, how do I know this is a polyp or how do I know this is a submucosal fibroid? Especially if it is smaller. ये वाला काफी clear दिख रहा है. Yes, by switching on the Doppler. If you switch on the Doppler and you find a single feeding vessel, it is likely to be a polyp. So a single feeding vessel is seen in an endometrial polyp. But if you see vascularity all around, it is likely to be a fibroid. So a Doppler will tell you how to differentiate between a polyp and a submucosal fibroid. Okay. So other tests for fibroids are HSG for submucosal fibroids, especially hysteroscopy again for submucosal fibroids, and laparoscopy is of course, but this is invasive. So you usually resort to doing invasive methods when you plan to actually treat the patient also. Okay. Now management, I've told you, so we end with management, but this will take another 10 minutes and then we're done for today. Okay, asymptomatic fibroids के लिए क्या करना है? Nothing needs to be done. So leave them alone, just reassure. Okay, but we can't leave them completely alone. We always have to do an yearly ultrasound to check that they are not drastically increasing in size, because a drastic increase in size could be a sign of malignancy. Though cancer, the risk is very rare, but we sound make sure that all is good. And irrespective of the size, we leave them alone. So size is not important. Acha, lagging, just give me a second. I'll connect to my phone again. 1 second. Sakshi, just the treat. Just let me connect to my phone. Phone बंद हो गया था मेरा. The fibroid is, the position depends on the size, depends on her fertility, whether she wants pregnancy or not. So a lot of things determine the type of management. Okay, Wi-Fi hai bache, but it's not working. I don't know why. So medical management, surgical management और others. Please repeat. Repeat क्या था? बस ये था. Asymptomatic में कुछ नहीं करना है. ठीक है, reassure yearly ultrasound बस. Symptomatic may either medical management or surgical management, and there's some newer options also. And this depends a lot on what her complaint is, where is the fibroid, what is the size, whether she wants pregnancy. It depends a lot on these things also. Okay. Now, so age, severity, size, location. Now, fibroids and infertility, I have already told you, agar patient has infertility and fibroids, Dhruv, what do you want me to do? अब सुनाई दे रहा है ना? अब now we can now is it okay now? Okay. So fibroids and infertility, remember, you will do a myomectomy. That is, you will remove the fibroid if, and I told you this before, you will remove all submucosal fibroids and large intramural fibroids, that is, those which are more than 5 centimeters or those that are distorting the cavity. Okay, these are the fibroids for you which you have to do a myomectomy. You have to remove them if she has infertility and she has been diagnosed with a submucosal fibroid, or she has a large intramural fibroid which is either more than 5 centimeters or which is distorting the cavity. Okay. Now coming to medical management. Now what are the medical management? So in surgical, so this is just fibroids and infertility. For all other patients, we can decide between medical or surgical management. Now medical management में just add here, सबसे पहले in fact वाला drug missing है, so just add here NSAIDs. Number one, the first drug of choice is usually NSAIDs, and we can choose to combine it with tranexamic acid, which is an antifibrinolytic. So the initial drug of choice in fibroids, especially if the complaint is heavy bleeding or dysmenorrhea, the drug of choice is usually NSAIDs. Okay? And to this, we can add tranexamic acid. Remember, the dosage is not important for anyone. Dose बिल्कुल भी याद नहीं करना है. जो मैं बता रही हूँ वो ही याद करना है. ठीक है? NSAIDs में yes, mefenamic acid is one of the better ones which we use, and we can combine it with tranexamic acid. Both NSAIDs and tranexamic acid will be symptomatic only. They will reduce the pain. NSAIDs will reduce the pain and they will reduce the bleeding, but they are symptomatic. Okay? With tranexamic acid, there is a slightly higher risk of DVT. Okay, so these are the first line drugs. Then you come to all the rest are hormonal drugs. These are the non-hormonal drugs. So obviously you will prefer the non-hormonal drugs first before jumping to hormonal treatment. In hormonal treatment, we have two types of drugs whose mechanism of action is similar. Both are selective progesterone receptor modulators. Mifepristone is also an SPRM, okay, which has a lot of anti-progesterogenic action. Ulipristal is also an SPRM. अब मिफेप्रिस्टोन हमने और कहाँ पढ़ा है? Where have we read about mifepristone? In MTP, very good, along with misoprostol. And where will we read about ulipristal tomorrow? Ulipristal main use is not in fibroids. It is as an emergency contraception. Very good. Emergency contraceptive है, ठीक है? So कल हम पढ़ेंगे इसके बारे में और डिटेल में. But remember, both will reduce the size and bleeding. Remember, fibroids have both estrogen receptors and progesterone receptors also. So based on the premise कि they may be progesterone receptors also, हम ये drugs देते हैं anti-progesterones. ठीक है? Now very important, this is not important, what you need to remember for ulipristal, it came into the market around 10 years back, and after a few years it was withdrawn by the FDA because of reports of severe hepatic toxicity, hepatotoxicity. Now it has been reintroduced. Last year it was reintroduced with a warning that it should not be given beyond 3 months. Okay, because of the high incidence of hepatotoxicity. So now very few people are now using it because सब डर गए. Okay, but it is a medical, it can be used for medical management of fibroids. Then we have GnRH agonists. GnRH agonists, they initially cause a flare up. Estrogen progesterone को एकदम से बढ़ाते हैं. फिर over time there is negative suppression of FSH LH, so estrogen progesterone goes down. So it suppresses the hormones, and this also reduces the size and the bleeding. The problem with GnRH agonist, example is leuprolide. And a problem with this is you cannot use it for a very long time because it sort of creates a state of pseudo menopause. It causes hypoestrogenism, and that leads to bone loss. Okay, so osteoporosis is a known complication with long-term use of GnRH agonist. And hence, if you're using it for long term, you have to add back. What do you mean by add back? You have to give back estrogen to prevent bone loss or tibolone. So we usually give add back therapy with estrogen or tibolone to prevent bone loss. Okay, so that is GnRH agonist. So when you give leuprolide, initially somebody is asking explain the suppression. So initially क्या होगा GnRH दोगे तो वो it will increase FSH LH, it will increase estrogen progesterone. So initially there will be a flare up, एस्ट्रोजन प्रोजेस्टेरोन बढ़ जाएगा, बट वो बढ़ा हुआ हार्मोन विल अगेन कॉज नेगेटिव सप्रेशन ऑफ एफएसएच एंड एलएच, सो इवेंचुअली इट लीड्स टू लॉन्ग टर्म ईस्ट्रोजन सप्रेशन करता है, ठीक है. Then we can give combined contraceptive pills. We all know, and we'll be discussing this tomorrow. OC pills reduce bleeding. तो HMB जहाँ पे भी heavy menstrual bleeding या menorrhagia है, it will reduce the bleeding. ठीक है? But again, it estrogen जहाँ होगा वहाँ पे it increases the risk of thrombosis. Then पुराने जमाने में my professors used to give danazol. Very commonly they used to give danazol for both endometriosis and fibroids. What is danazol? It is an anti-gonadotropin. Gonadotropin क्या होता है? FSH-LH. So basically FSH-LH को कम करता है. And hence it used to be a very good drug, okay, but it has gone into disrepute because it is highly androgenic. बहुत androgenic side effects होते हैं, hirsutism, acne, weight gain, bloating. It causes all this. So because of the high side effects, nobody uses it anymore. In fact, it's not even available in the markets. I think the last 10 years or so, I have not seen it being used by anybody. It's gone out of the markets. But it used to be a drug which was very very famous. तो पुराना एग्जामिनर अगर आपका बनाएगा पेपर तो वो हो सकता है पूछ ले, but now nobody uses it. Ulipristal बच्चे is not banned. It was banned in between. It was withdrawn from the market for a few years, but now it is reintroduced with a warning that if you are using it, you have to check the patient's LFTs and you should not use it beyond 3 months. ठीक है. Then we have the LNG IUD. We'll be talking about this tomorrow again. Mirena is the common one available. It is a progesterone containing intrauterine device. Now, whenever we have progesterones, okay, and we give them long term, one of the mechanism of action of progesterone, it causes endometrial atrophy. So, kal I will be discussing this. All the progesterone containing contraceptives, they are going to act by causing endometrial atrophy. By the end of 1 year, women who are using the Mirena become amenorrheic. Periods बंद हो जाते हैं. क्यों? क्योंकि endometrial gets suppressed significantly. So it causes atrophy. It also reduces the size and the symptoms of the patient. ठीक है? We'll be discussing the lifespan and everything tomorrow. Okay, but the only contraindication for a Mirena is if the fibroid is distorting the cavity. So a large fibroid distorting the cavity becomes a contraindication for putting in any intrauterine device. Cavity distorted है, Mullerian anomaly है, ठीक है, या बड़ा सा फाइब्रॉइड है, सब म्यूकोसल फाइब्रॉइड है, you can't put in a Mirena, you can't put in any intrauterine device, it will get expelled. ठीक है. So these are the different drugs that you can give, and drugs are usually given if the patient has heavy menstrual bleeding or dysmenorrhea, then we can give these drugs. PCM के बाद क्या लिखा है? PCM कहाँ लिखा है मैंने? PCM नहीं लिखा मैंने. Why does atrophy occur? Prolonged progesterone will suppress the endometrium. It causes atrophy. Okay. Now, surgical management, we have two things. We can either just remove the fibroid, which is called a myomectomy. This is removing only the fibroid. Okay. Or we do a hysterectomy. That is we remove the uterus. So you will want to remove the uterus in women who are on the older side. Family complete, usually women who are more than 40 or 45, you would want to do a hysterectomy because then there's no point doing only a myomectomy. It is technically a more difficult surgery associated with blood loss. It can recur. Why do you want to do a myomectomy if the easier option is doing a hysterectomy? FSH, LH कम हो जाता है. Gonadotropins are FSH, LH, these will reduce. Okay. So myomectomy or hysterectomy, these are your options. Myomectomy is usually reserved for those patients who are infertile, and hysterectomy is those patients whose family is complete. Now, some important instruments that you should know which come in the exam. What is this? This is a Bonney's myoma screw. This is used when we're doing an abdominal myomectomy, and this helps us hold on to the fibroid. It gives us traction. The fibroid is very firm in consistency. So this digs into the fibroid and इससे हमें traction मिलता है. Basically हम पकड़ सकते हैं fibroid को इस instrument से. ठीक है? This is another important instrument which is specifically used in myomectomy. This is a Bonney's myomectomy clamp. What is this instrument? So this instrument is applied. This is looking from above. ठीक है, ये यूट्रस का फंडस है, ये लोअर पार्ट है. यहाँ पे कौन सा वेसल आता है? यहाँ यूट्राइन आर्टरीज आर एंटरिंग हियर. So this is a clamp which is applied at the level of the uterine arteries during a myomectomy. Why do we apply this? Because remember, myomectomies are very, very bloody surgeries. बहुत blood loss होता है. So we look for ways to reduce intraoperative blood loss. One way of reducing intraoperative blood loss is by applying this clamp at the level of the uterine artery. We apply it for 20 minutes. And then we release, because if you apply it for longer than that, then the uterus can undergo ischemia and necrosis. So you have to replenish the blood supply. So 20 minutes lagao, fir kholo, fir lagao, fir kholo, like that. So this is going to reduce the intraoperative blood loss. So we try, while this clamp is put, utne time mein fatafat fibroid nikal do. So this will reduce the intraoperative bleeding. This is a submucosal fibroid. This is a hysteroscopy image, just trying to show you that you can easily excise the type 0 and type 1 fibroids. Hysteroscopic myomectomy can be done. Okay. This is just a picture showing you how multiple fibroids look like. So you have a large fibroid here, you have a fibroid here, and the uterus is actually this part. So you have two large fibroids on either side. This is a picture showing a large cervical fibroid. What is the typical way to describe this? Anybody can tell me? The uterus, chota sa uterus sitting on top of a large fibroid. It has a classical description. It's given in Shaw's. Yes, lantern on top of St. Paul's Cathedral is used to describe a large central cervical fibroid. ठीक है, ये this is the lantern, छोटा सा uterus sitting on a large cervical fibroid. It's just a term, lantern on top of St. Paul's Cathedral. This is a hysterectomy specimen showing a large fibroid polyp. The polyp has been so large कि वो cervix के बाहर ही आ गया, probably vagina के बाहर भी दिख रहा होगा. So this is a patient who's going to present with intermenstrual bleeding. ठीक है, she can also present with a vaginal mass if it comes outside the introitus. Okay, so this is a hysterectomy specimen. The uterus has also been removed with the fibroid. Now, there are two newer management options. These are done in those patients who don't want surgical option, don't want medical option, and also whose families are complete. So they are preferred in patients whose family is complete because they significantly reduce the blood supply of the uterus. So if the blood supply is cut off or reduced significantly, they have increased chances of complications in pregnancy. One of them is MR guided focused ultrasound. Just remember the names. MR guided focused ultrasound. Okay, and the other is a uterine artery embolization. So these two are newer methods which are minimally invasive or non-invasive, in fact. Okay, So surgery is avoided, and therefore those patients who don't want to be keep taking tablets every day, तो medical भी नहीं चाहिए पर कोई surgical नहीं चाहिए, but family complete होना चाहिए. If they want pregnancy, it's not a good option to do these two things. Okay, now let's do some questions and then we end. The instrument shown below is useful in which surgery? Cathedral on top of St. Paul's, sorry, lantern on top of St. Paul's Cathedral is the term used to describe a central cervical fibroid. 34-year-old infertile woman is diagnosed to have this came in NEET PG 2022. Large 7 centimeter intramural fibroid distorting the cavity as shown on the scan. What is the best management option? So, large fibroid distorting the cavity, you will want to do a myomectomy. The fibroid has to be removed. Even if she later on decides to have IVF or whatever, you still have to remove the fibroid because it's so large कि IVF भी नहीं चलेगा. GnRH, so medical management is usually not preferred if she has infertility. I told you myomectomy needs to be done. Uterine artery embolization is not a good option for patients who want pregnancy. Identify this instrument, easy. Bonnie's myomectomy clamp. Okay. Question that can come here is suppose you don't have the clamp. What can you use instead? Instead of this, you can also use a red rubber catheter. Basically, you want something which will act like a tourniquet around the lower part of the uterus where the uterine artery is entering. Okay. No, it is not straight. It has this slight angulation because pelvis में लगाना होता है ना तो थोड़ा सा angulated होके नहीं तो straight होगा you will not be able to go deep inside the pelvis. Red rubber catheter. देखा है ना red rubber catheter? Like a Foley's catheter, but it's just a simple pipe. You can even use a Foley's catheter for that matter. Something to just tie around the uterus. Okay. A 45-year-old, a similar question came in NEET PG. I have that question also. A 45-year-old underwent hysterectomy for AUB. The cut section of the uterus is as shown. So what is this? This is a very large submucosal fibroid. It's a submucosal, not subserous, submucosal. Cavity के अंदर है ना, you can see the cavity around. यहाँ दिख रहा है cavity, ठीक है? और यहाँ पे it looks attached to the uterus. So probably a type 1 fibroid. It's a submucosal fibroid. There were some more questions on fibroids, which I think I put after endometriosis. Just 2 minutes, then we end, huh? Some of those questions are, yeah, this was the question. Identify the image. This is this year's NEET PG evening session. So what is this? There was a lot of confusion between fibroids and adenomyosis, but what do you think this is? This is very similar to the picture I just showed. This is a fibroid. It has nice white lesion inside. So it is a fibroid. Adenomyosis kaise hoga? Adenomyosis is going to be a generalized enlargement of the uterus. You won't see this change in color. Adenomyosis hoga to the whole uterus will be enlarged. It will be pink in color. Okay, so this is a fibroid. So we'll end today here. It's getting very heavy for some people. So endometriosis and these are very small topics. So कल ये जल्दी हो जाएंगे. Endometriosis, adenomyosis, AUB, and then we go to contraception and oncology. No continuing Vedant. Even I am tired now. It's going to be 1 o'clock. Okay, so we continue tomorrow. And tomorrow we start at 5:30 sharp. आज थोड़ा सा late भी start हुआ ना, half an hour late. So tomorrow we start on time and we finish everything. Okay? So good night, everybody. 5:30, 5:30. Good night, good night, good night.